Okay, I hope everybody can hear me, and we're going to go ahead and get started here. And this is where we stopped yesterday, and we were talking about things that affect the heart rate. Um, Remember, the heart is a self-starter. It is a functional syncytium, meaning it has autorhythmic cells that tell the entire heart to contract as one big cell every time it contracts. We can affect the heart rate by different ions. Calcium and potassium can affect the heart rate, or an absence of calcium and potassium. Epinephrine can increase the heart rate. Uh, we know that acetylcholine can slow the heart rate down. We know that there are outside factors that will help to uh, not, well, I guess regulate's a good word. It doesn't initiate it, but it can regulate it. We see that other things like our age. When we are in utero, we have a very fast heart rate. This slows down. We don't have the need to be pumping blood as quickly as we get older, even though our bodies get larger. Uh, on the average, a female will have a higher heart rate than a male. Their resting heart rate may be, um, you know, 10 beats a minute higher than a male. Exercise increases the heart rate. We know that because our bodies burn glucose and release CO2. We have to get rid of the CO2. Excuse me. We have greater demands for CO2 removal. We have greater demands for moving glucose in and taking waste products out. And of course, we like to pick up more oxygen as we exercise, even though we have plenty of oxygen. We know that an athlete who has significantly trained his body or her body through exercise can have a trained heart, which will have a slower heart rate, but it will likely have a more efficient heart rate. The heart rate may be slower, the stroke volume can be greater. And we also know that our heart rate goes up and our temperature goes up. The hypothalamus is our thermostat of the body. The hypothalamus is telling um, changing our body temperature. So our heart rate goes up to try and relieve or release some of this extra heat, or to conserve the heat. If our body temperature drops, for example, then our heart rate will change to enable us to send more blood to our core as opposed to the extremities because we don't want to lose heat. On the other hand, on a hot day, we're increasing the blood flow to the skin, surface to the skin and to the extremities to try and release some of this extra body heat. So, problems with the heart. We have a condition known as congestive heart failure, CHF. It's progressive. It means it doesn't get better on its own. It continues and worsens as time goes by. The cardiac output from a congestive heart failure patient is typically so low we can't meet the perfusion needs of the tissues. We're just not getting enough blood out to the body for the systemic needs or for the respiratory needs. Now, what causes congestive heart failure is weakened heart muscles. The myocardium becomes weaker and becomes softer, it becomes flabbier or more flabby. And so it can't continue to pump at the same efficiency it did when it was healthy. What causes this? Well, coronary artery disease, what we call atherosclerosis, or the old term, hardening of the arteries. Many people might not be able to understand atherosclerosis, but they definitely know hardening of the arteries. And what will happen is that with this atherosclerosis, arteriosclerosis, fatty deposits called plaque accumulate inside our coronary arteries. The coronary arteries are the arteries supplying the muscle cells in our bodies, I mean, in our heart. And just like any other cell, we need oxygen, we need to take away CO2, we need glucose. If the arteries are going to get clogged, which they can, because It has to do with the presence of fat and cholesterol. Excessive fat and cholesterol accumulation leads to a substance known as plaque, which forms in the coronary arteries. We know that the low density lipoproteins that transport cholesterol will bring large amounts of cholesterol out to the arteries in the extremities, particularly in the heart. It will bring it from the liver out to the heart and other organs, but it won't bring it back. And so it stays there and it can accumulate. The more you cholesterol and more fat that you're sending through your system, the more likelihood it will accumulate on the inside of these coronary and cerebral arteries. On the other hand, high density lipoprotein is designed to bring excess cholesterol back to the liver for destruction. So it isn't a function of do we have cholesterol, but do we have too much cholesterol, too much fat? Do we have not enough HDLs and too many LDLs? The low density, the LDLs are what is going to be bringing this cholesterol in there. And once we clog the arteries, they're not going to unclog on their own. So what will happen is we are depriving the muscle tissue downstream of a clogged artery. If an artery clogs, coronary artery clogs halfway down its length, then it's impairing blood flow to the muscle cells below the blockage or the partial blockage. And yes, indeed, it does alter the ejection fraction because if you can't pump adequately, how are you going to, your stroke volume is going to drop every time. You're going to have less and less blood going out to the body. So now not only are you impairing the heart, but you are affecting the supply to all the other organs of the body too. So the muscle cells are going to become weaker because they're not getting supplied with enough oxygen and taking away the CO2. So the muscle cells become weaker and it will no longer contract as efficiently as it did. So what you're pumping out, your stroke volume values are going to be dropping. And to try and maintain that, the heart will have to work harder. Um, and so the heart tries to work harder to compensate. And that's where our heart starts to enlarge as it's trying to compensate. It's failing at its job. It can't get as much blood out per stroke volume, so it starts beating faster, or trying to anyway. And so as it gets faster, you're still not getting enough oxygen to the muscle cells, and they're going to get weaker. And the weaker it gets, the larger it gets. And so we have this a constant state of partial hypoxia, not enough oxygen delivery in the coronary muscle. And it's a progressive disease. It only ends one way. And it does not get better on its own. This is what happens with congestive heart failure. Now, typically we know that the left ventricle is larger and has thicker walls than the right ventricle. But what will happen is that the muscle cells will continue to, we won't hurt the muscle cells, but they'll get bigger. They'll get bigger, but they'll get weaker. Here we see on the left-hand side is this very large, thick structure. That is the left ventricle that has enlarged. The right ventricle on the right side of the picture is of normal size. The right ventricle is reasonably healthy. The left ventricle, unfortunately, has gotten so large that in compensation, well, larger isn't better. It doesn't pump very well. A large heart, an enlarged heart is a very poor pump. So and it isn't just coronary artery disease. High blood pressure can do the same thing, causes enlargement. The higher the pressure, the more the heart has to work, the greater resistance you have throughout the body, and so the heart's getting weaker. Person who has had multiple infarcts, myocardial infarcts, a heart attack, is going to maybe have and survive, may have scar tissue. You know, you know, the heart can, if it recovers to some extent, there's going to be, if there's been no treatment and they survive the heart attack, the tissue downstream of the blockage, we're going to get into that shortly here, won't recover properly. And so it's now scar tissue and it's weaker than it should be. So it doesn't pump as efficiently. So therefore, a person who has had several heart attacks and had recovered from them, didn't get stented, didn't get anything done. That's pretty much how it was 50 years ago. Um, the um, the heart is now weaker. It may only be 80% efficient or 70% efficient. And of course, we have a condition known as dilated cardiomyopathy. The heart is getting weaker and weaker and contracting uh, less efficiently each time. A congestive heart failure and high blood pressure, if your pressure in the aorta is continuously greater than 90, okay, well, typically, we see 190, somewhere in that range. But we're saying upwards of 90, 100, 110, 120, 130, 140. The harder, the higher the pressure in the aorta, the greater the heart has to work to pump blood. The myocardium has to force the blood when it's ejecting its stroke volume. It has to work harder to try and maintain a constant flow. The right side, the pulmonary trunk, pressure in the pulmonary trunk stays really low, typically because we like to have low pressure blood going to the lungs. It's unusual, but not impossible, to see an enlarged right side too. But when we talk about an enlarged heart, it's often the left ventricle that enlarges. And uh, I think I may have said this before, but about 10 years ago, we were able to take a couple of classes over to Pellissippi. We had a connection over there, which we no longer have, to see the cadaver labs. And we were there to watch them dissect several cadavers. And when they opened up the chest, the heart was incredibly enlarged. It was the size of a football. The cow hearts we're going to see on Thursday would be pretty fair comparison to the size of this one individual's heart, because obviously they had died from an enlarged heart, congestive heart failure, coronary artery disease, you name it. But the the heart itself had enlarged in trying to compensate for its reduced strength. Of course, the same thing happens with the heart attack. Um, Typically, what will happen is if you have a blockage in a coronary artery, and it becomes a complete blockage, then you have what we call a myocardial infarct, which is a nice way of saying blockage. What will happen then is there's no blood flow going downstream uh, below the blockage to adequately perfuse the muscle tissue uh, that artery was feeding. And you have about an hour to get that artery reopened with a stent. But if you don't get it reopened, then the muscle tissue dies. Uh, so, uh, conventional wisdom 50 years ago was a person has a heart attack, they're given nitroglycerin, they're given morphine sulfate for pain, they're treated with oxygen and adrenaline, and you hope and pray that they recover. So what will happen is the scar tissue, the tissue below the blockage, will die after an hour. And if your patient survives that, they're not out of the woods. Because what would happen is because it's dead tissue, we have macrophages in our body that take out dead tissue. And so they would go into the heart and remove the dead tissue before any scar tissue can go in. Scar tissue that replaced the dead tissue doesn't do anything. It's a placeholder. It doesn't contract. It doesn't respond to stimulus. So if you survive the first event, the first blockage, and then if you survive the removal of the dead tissue and put in scar tissue, your heart is whatever less efficient than it was before, because now maybe 10% of your heart muscle is going to be fibroblasts made out of fibrocartilage, or you know, scar tissue, fibrocytes. That's what I was looking for. Uh, it doesn't do anything. Or maybe it's 20%, or maybe it's 30%. Or in worst case scenario, as your macrophages are busy eating away the dead uh, muscle cells, they expose one of the arteries, and now you bleed out, 10 or 12 days after the first infarction. So many people would survive the first event and then die a week or 10 days later. If they did get past that period, then the heart is permanently weakened at that point. So that was conventional wisdom 50 years ago. So now our heart is pretty amazing. It can survive a lot of trauma. It can survive a heart attack, a myocardial infarction. Um, there's no guarantees that someone is, as I say, they're having a heart attack. Uh, you know, well, that doesn't necessarily mean that they're going to be dying from it. The heart can survive penetrating injuries. Both of these injuries we see here, uh, a arrow, uh, light from the look of it, it looks like it's probably like a target arrow, um, but still, it's an arrow in the chest penetrating the heart. On the right is a roofing nail that has entered the heart. Now, the heart has this amazing capacity to seal up around the injury. If there's a penetrating injury to the heart and it doesn't cause extensive trauma to the heart, like the heart's not ripped apart, but it's just a like an arrow, then once that's removed, the heart can be repaired. Now, the key, of course, is to leave the object in place uh, to until they're in surgery. If you remember the crocodile hunter um, who died when he was stung by a ray off the coast of Australia. If you remember, um, his first reaction was to yank these very large rays have uh, a pointed little spear, not a spear, but this calcified point at the end of their tail, and it contains venom. And so they can defend themselves, they can attack things. And so Steve Irwin, being who he was, uh, grabbed a hold of the ray. The ray fought back and jammed him right in the heart with his the pointy end of its tail. Well, his first reaction was to yank it out because A, it hurt, and B, it really hurt. Well, if he hadn't yanked it out, he likely would have survived, even though it penetrated his heart. But when he yanked the barb out, he bled out. So in cases like this, you know, there are numerous cases of individuals who had penetrating injuries to the heart and survived as long as the object wasn't removed until they were ready to go into surgery. Something we've heard about a couple that became more well known a few years ago is a condition known as commotio cordis. Blood force to the chest in the area of the sternum can cause the heart to stop. No damage to the heart suddenly stops. Um, if you remember the football player from Buffalo who went into cardiac arrest on the field after being hit in the chest, there is a time period right after the QRS and before the T wave that is the high risk factor. Now, how do you know where you are? You don't know where you are. You know, um, generally it occurs in contact sports. You know, uh, baseball players hitting the chest with a ball, football players hitting the chest, martial arts exhibitions or contests. Strong blow to the sternum. Um, you know, a younger individual who has a healthy heart will suddenly go into cardiac arrest after receiving some sort of blow to the sternum. It may very well be that the blow itself releases enough electrical energy of its own to create a depolarization wave to essentially short circuit the intrinsic conduction system of the heart itself. And if people know what's going on, the individuals that are affected can be treated. There's, you know, who expects a 20-year-old or a 15-year-old to go into cardiac arrest? Well, lately I've been seeing more and more instances of that in the news of people that young athletes are experiencing cardiac arrest at various times. Now, maybe I'm just attuned to it because, you know, uh, talking about it, but it does seem like it's popping up a little more frequently. So now our heart will change over time. We have to treat the heart like any other muscle. We have to keep it healthy. We have to exercise and exercise the heart. But what will happen is over time, and this is not a guarantee it's going to happen, is we're going to see the valve flaps can thicken, they can become calcified, they can become covered with scar tissue. That's the sclerosis. We particularly see problems with the aortic semilunar valve because that's the one that has to deal with the high pressure all the time, with pumping high pressure blood out and having high pressure blood come back and slamming up against it. We see our cardiac reserve may lessen over time. We are trying to send more blood out, or maybe we're just not receiving as much blood. So we're trying to keep our stroke volumes constant. We have less blood in reserve. Our muscle can can weaken. It can become more fibrotic, as they say. It can become more useless tissue for whatever reason. And of course, the reason that we see, you know, as coronary artery disease as the number one or number two killer in the U.S., depending on, it fluctuates between cancer in all forms and heart disease, is lifestyle changes that promote, atherosclerosis. Now, it's interesting that the number of people that are dying every year from coronary artery disease is has maintained itself somewhere between the 600 and 700,000 range for years. And while that sounds like we're not making any improvements on deaths from coronary artery disease, remember that our population has increased probably by 150 million from the 1950s. And the death rate was still 600,000, more or less, in the 1950s. So while our population has increased, the overall death rate has dropped as we are more aware of the need to maintain a healthy heart. We've changed a lot of our dietary habits too. You know, um, let's go back 70 years ago in the 1950s. The typical American breakfast was bacon and eggs and coffee uh, every day. You know, nothing wrong with bacon and eggs, uh, but bacon and eggs every day does a lot of cholesterol and fat loading, probably a lot of salt loading too. Um, the typical evening meal was meat and potatoes. You know, a starchy, maybe a starchy food, a starchy dessert, very little vegetables, very little greens. The healthiest food on the plate was probably the protein-based meat, whatever it was. So we've learned over, over the past 70 years what is a healthier diet. We've gotten away from the meat and potatoes and gravy to, much healthier meals. That doesn't mean we're always eating healthy. Uh, the thing that is working against us as far as heart disease is our over reliance on prepared foods and fast foods. As as the consumption of that is going up. And I'm not picking on McDonald's at all, or anybody else. Um, but you know, those foods typically are high in salt, and they used to be higher in fat than they are now, but they are less healthy than something that is prepared fresh. And that's all I want to say about McDonald's or Burger King or anybody else. So, okay, I mentioned this earlier, and this is something that we can't um, emphasize enough here about the role of cholesterol. We talk a lot about cholesterol. We hear a lot about cholesterol. 20 years ago, when we talked about cholesterol levels, if you had a total cholesterol number of 200 or under, you were considered healthy. The magic number was 200, sort of like our blood sugar, our blood glucose number. If it's below 100, you're you have you're not you don't have excessive glucose in your blood. We found that it is the lipoproteins that are really the key here to the amount of cholesterol and how it's being used. Most of our cholesterol is carried by these low density lipoproteins. Um, the low density lipoproteins, what we call it, for one of a better term, the bad cholesterol, made in the liver, and the LDLs carry cholesterol from the liver out to the tissues. That's great. That's their job because we need cholesterol. We have to have cholesterol for steroid hormones. We have to have cholesterol to reinforce our cell membranes. So it isn't like we can just cut out cholesterol completely. The LDLs carry the cholesterol out to the cells. The cells use the cholesterol that's brought to them. If they don't use all of it, if there's excess cholesterol, then it's going to stay there and accumulate. After all, 70% of the cholesterol is being moved around by our LDLs. What we need then is a second lipoprotein, the HDL, the high density lipoprotein, to bring the excess cholesterol back to the liver where we destroy it and then we can excrete it. So it's a balance because we need cholesterol. You know, you know, the food industry has simplified our understanding of cholesterol too much. Many food items that are labeled, they say cholesterol free, and yes, they're cholesterol free. That's fine. Many foods are cholesterol free. That doesn't mean that they're any better than any other foods. It just means they have no cholesterol. We need to eat all sorts of foods to meet our dietary demands. The It is the excess, and it comes down to the excess word. Uh, Excess fats in our diet, excess cholesterol in our diet, can lead to accumulation in the arteries and arterioles supplying the tissues. So we use HDL, high density lipoproteins, what is often referred to as the good cholesterol, to bring the cholesterol that we don't use back. We don't want to leave it out in the coronary arteries, for example, and accumulate and thicken the lining on the inside and make it obstructed and obstruct the lining. It does sound counterintuitive that, high density lipoprotein HDL is the good cholesterol. You would correlate high with higher levels, but that's what you want. You want HDLs. You want to keep a balance between HDL and LDL, and you want to have low LDLs and high HDLs so that you don't have, you're not running the risk of cholesterol accumulation in the arteries. Okay. What happens here is the plaque, the fatty deposits of cholesterol and the triglycerides will combine to form a substance known as plaque. And it finds a home on the inside lining of these blood vessels and makes them very sticky. And so substances in the blood, and there are other lipoproteins besides the HDL and the LDLs, substances in the blood, lipoproteins and the calcium, uh, a platelet or two or a dozen, will stick to this new sticky lining. Remember, because normally the blood vessel is lined with endothelial cells. It is like it's non-stick coated, if you will. You know, it is a should be a perfectly smooth surface so blood can flow with no obstructions. Well, now it's sticky, and everything that comes in contact with that sticky surface will adhere to it, and that will, accumulate. And as more fatty deposits come into that location, they're going to stick to the wall too. And so our coronary artery gets narrower and narrower as we accumulate more and more of these fatty deposits. Now, we can do workarounds. We're blocking our artery. You end up with a 95% blocked coronary artery. Now, thanks to angiogenesis, you can develop small blood vessels that do a workaround the blockage. And so they're going to continue to allow oxygenated blood to perfuse the tissues downstream of the blockage. 5% of the blood that's coming through the coronary artery is getting through, the rest is being blocked. But these little little arterioles or little even capillaries are doing the workaround to get past the blockage, but they can't respond to any type of stress. Exercise, emotional stress can trigger a complete blockage of the artery. That's often the trigger that occurs. The trigger is often some sort of shock to the system, either physical or emotional. A person with a 95% blockage has a myocardial infarction because the artery is completely blocked. The smaller blood vessels that have been created around, angiogenesis, genesis, creation, angio refers to blood vessels. These small vessels that have been created around the blockage can't keep up with the demand. So your patient ends up with a full blockage, chest pain, shortness of breath, damaged tissue downstream of the blockage if we don't remove the blockage in an hour, or death. Yeah. And so this is what it looks like. Cholesterol. It's carried along here with the triglycerides and the cholesterol. It's being brought out to the tissues with low density lipoproteins and taken back to the liver with the HDLs. If we don't remove it and we have excessive amounts of cholesterol, it will start forming this fatty deposit known as plaque. That's this yellow stuff supposed to be here on the inside lining of these arteries. It can be the coronary arteries, it can be the cerebral arteries. So, and the end result's going to be a blockage or at least a narrowing of the coronary artery. Here's a normal coronary artery up here at the top. Non-stick surface, wide open blood flow. What we're looking here is the anterior descending coronary artery, and we'll get over to the names next week when we go through blood vessels. But this is the right coronary artery over here. This is the left coronary artery here. This is the anterior interventricular artery, because it's in the front and it's running down. It has a couple different names. So this is the anterior in the front, interventricular running down across the top of the septum artery. It branches off of the left coronary artery. The right and left, there's the right coronary artery. The right and left coronary arteries come off the aorta as soon as the aorta leaves the left ventricle. The right and left coronary arteries branch off. So the first 5% of the blood supply leaving the heart is immediately returned is being immediately returned to the heart muscle itself. So the heart is taking care of itself first of all. Yeah, it's getting the first blood leaving the heart, the fully oxygenated, low in carbon dioxide, uh, high in glucose, is going into the right and left coronary arteries to supply the heart muscle. The other 95% is going, over here. You can see, there's the aorta coming up in red, coming up and going to the body. That's got the other 95% of the blood supply. Now, atherosclerosis will cause the artery to narrow. If we have excessive cholesterol, excessive fat in the diet, we'll have this narrowing here. It makes the surface sticky, and instead of being a non-stick surface, things accumulate. What will happen here that leads to the crisis is going to be if a platelet sticks to the surface and starts releasing platelet factor and drawing in all of its friends and neighbors. When that happens, we get a platelet plug, which very quickly becomes a clot, and that completes the blockage of the artery. So we have a blood clot blocking the artery. So everything downstream of that artery is shut off. It's not getting any oxygen, not getting any nutrients. So um, the problem has grown from a good, healthy artery to a partially obstructed artery to a completely blocked artery. And we don't know what's going to cause the blockage. It could be stress, it could be random chance, it could just be, whatever. Many people are alive and functioning with 95% blockages, but and they may not even know they have a 95% blockage, but they notice that they can't climb stairs very well, and they become short of breath very easily. They seem to have those things, and it's just a matter of time. So, how do you fix this? Well, there are medications, of course, that will reduce the plaque accumulation in the heart. Uh, we can control hypertension with medication. We can do a bypass where we actually go around the blocked artery with another artery or with a large vein. We can go in with what's known as angioplasty, where we thread a catheter up from one of the arteries in the leg or veins in the leg up into the heart, and we run this balloon into the blocked artery. We inflate the balloon, that compresses the plaque, and then we drop off this little metal stent, a little framework that keeps the artery open. And it's probably the least invasive procedure other than drugs and medication, is you don't have to open up the chest, you don't have to crack the ribs and open up the heart, or at least work on the heart. You're doing it, internally. So we know that obesity is a major contributor to coronary artery disease. And you saw when we looked at the instance of type 2 diabetes in the US, that diabetes and obesity tracked together very nicely, from a statistical perspective. As obesity rates went up, diabetes rates went up. Well, obesity also leads to coronary artery disease because excessive eating, excessive consumption of high fat, high carbohydrate, uh, high cholesterol foods are going to contribute to coronary artery disease. Of course, my first question when I see this slide is always, where'd you get a pizza that big? But that's neither here nor there. The point is that we know that we have an obesity issue, health issue in the United States, particularly here in the South. So here we are. Here's our obesity rates just a few years ago. Tennessee is at 33.8% of the population is obese. Let's see. Louisiana wins with 36%, and Texas has the least obese at 32%. The 4 percentage point difference between the most obese state and the least obese state. A third of the population is still uh, considered obese. And that's going to reflect itself over time in continuing to see a rise in uh, coronary artery disease, what we call heart disease, high blood pressure, strokes, and death. So here we see, and this hasn't changed. This is 5 or 6 years old. Um, but if we compare the obesity rates in 2018 on the left, and we see the highest obesity rates are across, in this area uh, in the South, and of course, Kentucky and West Virginia. For some reason, North Dakota has high rates of obesity too. Um, and we see the Western states tend to have, uh, you know, they are less than 25%. These dark red area states are greater than 35%. And now we go over here to mortality rates, and we see that the pattern tends to match itself. Um, and this is county by county, and you can see, if you could load this up, you would see the death rates, uh, you know, um, are excessively high in many of these same southern states that you see over here with the obesity rates. Now, some of this data is skewed based on the population centers. One of the reasons North Dakota may have high rates of mortality and high rates of obesity is because the two large population areas here, which are skewing the whole state. You know, a lot. The bottom line is that we can definitely visually see the comparison between high obesity and death from heart disease. Yeah. So here we have uh, an angiogram. An angiogram is an X-ray of a soft tissue structure in the body with some sort of radio-opaque dye in it. Um, and here we see the circumflex artery. Circumflex artery, as you'll see on Thursday, is an artery that circles the heart about the level of between the atria and the ventricles, so that our blood supply in the heart is extremely redundant. We have numerous arteries that connect and connect again to other arteries, so that if we do have an issue with one artery, we can have we can shift blood flow to another area. That's not a fix. That's just a temporary arrangement. The a blockage, though, a blockage is permanent. You have a blockage in the coronary artery. Here you have a blockage in the circumflex artery. So everything that the circumflex artery in that is feeding in that one location is going to be deprived of oxygen and nutrients. And it's going to cause, if uncorrected, it can lead to enlargement of the tissues or ultimately death through a myocardial infarction. So this is the problem right here. We have a blockage of an artery. And how do we fix it? Well, here we see um, a person with, this is an image on the left-hand side of a 95% blockage in the left coronary artery. So this is the left coronary artery right here. There's the blockage. Here is the anterior descending artery, um, which is also called the interventricular, anterior interventricular artery. Anyway, so we have a blockage right here. Here is the left circumflex artery. Here's the left coronary artery. Here is the descending artery down here. Here, if we look here, different perspective, here, if we turn the picture, we can see here is the left descending. That's the same one that's over here. Here we have the left circumflex here, so we're looking at those up there. But again, we have almost a complete blockage at the left coronary artery. And this is what we call the widowmaker, because if you block the left coronary artery at the junction where the circumflex and the anterior descending separate, if you block the coronary artery there, then you take out almost the whole left ventricle's ability to function. Because these two, the left coronary artery, the left circumflex, and the anterior descending artery, the three of those are feeding nearly the whole left ventricle, and then everything else is coming off of that. You make the blockage right here, where the red arrows are, or even over here, then the whole left side of the heart's affected. And this is the reason this is called the widowmaker is for years, well, among other things, for years it was thought that women were immune to coronary artery disease, and it was mostly killing males. And this would be the one where the male patient was 60 years old and was in a stressful situation and suddenly, as they say, dropped dead right there. Well, that's what would happen. You would block the left coronary artery at the junction of the anterior descending and the circumflex, and the whole left side of the heart would suddenly be deprived of oxygen. Uh, Now we know we can fix that, and if we get to it within an hour. But for years, that was when your patient just, as they say, he had a heart attack and died because the technology, the treatment to repair that, to fix that, wasn't around 50 years ago. And that's why it's called the widowmaker. Because it made widows of the women whose husbands had died. It turns out that women don't have genetic heart disease. It was a change in society that had to show that. Because up until the 1960s, women didn't enter the workforce uh, uh, equally like they do now. And so most of the workforce up until the 1960s was male dominated. And so the stresses of work were primarily being exposed to males. Once women started entering the workforce in great numbers, they started dying at the same rates. They had the same stress applied to their hearts that the male counterpart was. And so the illusion of immunity to heart disease was destroyed. You know, they die just as easily. A woman dies just as easily as a man does from heart disease. Now, if you were to do a population study and you went back and started looking at cemeteries, you'll often see that for a long time, you have a husband and wife paired tombstone, and the husband dies at 60 and the wife dies at 85. That wasn't unusual for a long, long time. Now it has changed. There's been as they say, a demographic shift in the dying rates. Now, how do you fix this? Um, Here we have on the left a 95% blockage in the coronary artery. And if we put in the stent, the procedure is to run in this little catheter up into the artery. You can see the metal uh, line here is the catheter. The stent contains a balloon, a deflated balloon that's inflated to compress the plaque away from the artery, reopen the artery. And angioplasty was a procedure frequently done for the longest time without a stent, but it was found that if you compress the plaque and reopen the artery, it would come back. So if you drop the stent in this little metal frame, then the artery would stay open. Uh, the endothelial cells would grow over the stent and form the smooth surface again, and you wouldn't have to get back in 3 months and inflate the balloon and compress the plaque again. So here we see the stent in place, and this is that same artery reopened with zero blockage because of the procedure that the catheterization, stenting, angioplasty followed by a stent. So procedure is pretty straightforward. The most difficult process is the recovery time where your patient has had a stent put in and they need to stay immobilized for 12 hours, as it was not that long ago. So here we have a partly blocked artery. Here comes the balloon and the stent. The balloon is inflated, compress the plaque. The balloon is withdrawn, and the stent itself, the little frame, is left behind. We come in through artery here in the abdomen. This is what the stent looks like. You know, the metal tube itself, metal framework itself, is compressed along with the balloon. When you inflate the balloon, you inflate the stent, and then the catheter draws the balloon back out. And what's left behind is this structure here, which works very, very well for individuals. It is a minimally invasive procedure. And I can't say enough good things about stenting as opposed to cracking open someone's chest. Okay, problems, the arrhythmias. Those are heart rhythms that are not correct. They are irregular. It may be atrial fibrillation. It may be bradycardia. It may be tachycardia. It can be, you're getting a QRS complex in the middle of the rest cycle. You get a P wave, a QRS, and then another QRS, and then a T wave. You may get a QRS prior to the P wave. What we call a preventricular contraction. The ventricles contract before the P wave causes the atria to contract. There's any number of things that can go wrong. So those are arrhythmias. Now, fibrillation, it comes in two categories. It's either atrial fibrillation or AFib, or ventricular fibrillation or VFib. AFib causes the atria to contract out of sequence. Well, we know that the atria are only providing the last 20% of the blood flow into the heart. So we can adjust to that. We can accommodate that. AFib can be annoying, it can be painful, or it can, in some cases, lead directly to ventricular fibrillation. With VFib, you have uncontrolled quivering of the heart with no effective pumping. Remember, with atrial fibrillation, the ventricles are still pumping just fine. It's only the atria that aren't going to contract well. But for most of their time in the cardiac cycle, the atria are relaxed and letting blood flow through them. So even if they're quivering, as long as they're letting blood flow through them, they're still doing their job. It's only when they contract and top off the last 20% of blood going into the ventricles is when they're supposed to be active. So many people experience AFib. In fact, it's been said it is the most common arrhythmia in the world. That it's been more and more people are experiencing AFib than we knew 10 years ago, for example. Now, the SA node can also cause a problem for us. The SA node is the pacemaker of the heart. It sets up in the upper back wall of the right atria. It is autorhythmic cells that will fire every 7/10 of a second. They will trigger a depolarization wave that spreads across the atria. down to the AV node embedded in the interatrial septum, the wall between the two atria. Um, that will slow down the depolarization wave by a tenth of a second, and then that signal will be directed through the bundle of His, which is the only electrical connection, go down the bundle branches and up the Purkinje fibers. If the SA node becomes defective and doesn't fire, then typically the heart will switch to the AV node. The AV node will give you a rate of about 50 beats a minute. Very survivable. Um, if the SA node is non-functional, the AV node will function. Um, but again, it's giving you a lowered heart rate. So, because the signal is no longer starting with the atria. Does that mean that the atria aren't contracting well? You're depending on the SA node to cause the atria to contract first. So the ventricles will still work and they will still pump blood. Remember, blood is still going to flow passively into the ventricles for most of the rest, for the entire rest phase of the cardiac cycle. Sometimes we get an extra contraction. Sometimes we get a preventricular contraction. Sometimes we become overstimulated, too much coffee, too much nicotine, um, you know, various stimulants might work, might trigger this. You get an extra contraction here when you shouldn't. You get a P wave, a QRS, a T wave, and immediately have another P wave, QRS, and T wave. You haven't had time for ventricular filling to be completed. You may have a preventricular contraction right before the first P wave. Any number of things can happen here if the SA node isn't functioning properly. So, and this is I can't emphasize AFib enough. It's not considered imminently dangerous to most people. We know that normal sinus rhythm is triggered from the SA node. Um, and the SA node will, you'll see the pathway there. We've talked about this enough. We cause a contraction of the atria, and we go into the AV node to slow down the signal. But in atrial fibrillation, we have a disconnect here. In atrial fibrillation, you see it on the EKG that we don't have a defined P wave. We get a QRS and a T wave. We may have a P wave. We may not have a P wave. It, again, it is not immediately life-threatening. It may never be life-threatening, but it will cause a quivering of the atria. And for patients that have that, it's supposed to be very uncomfortable. On your EKG, it would show up looking like this. You're getting your QRS and your T wave, and then we get these flat-topped waves here, and that may be a P wave or maybe not. So we're not certain on this. Another thing we encounter is a condition known as angina pectoris. This is what you have someone who they complain of chest pains and they open up a little bottle they have with them and take out a nitroglycerin tablet. With angina, the cardiac muscle cells are not getting enough oxygen because they're not getting enough blood. And so it causes pain. There is a temporary spasm of the coronary arteries, reducing the blood flow to the muscle cells. And so lack of oxygen, even though there's plenty of myoglobin present, a short-term lack of oxygen causes what we call a transient or temporary pain. Your patient will treat it by taking a nitroglycerin tablet. Nitroglycerin is a vasodilator, and so the vessels dilate to increase blood flow, and the pain goes away. Now, The problem is that angina can cause the cells to weaken as they're not getting their oxygen supplies like they need. A person may walk up 2 flights of stairs and have chest pains. They may be stressed and have chest pains. It may be that is likely as a cause from angina. Uh, yeah. A person with heart disease may have angina, and so they take their nitroglycerin tablet, and that causes a body-wide vasodilation. It brings their blood pressure down, opens up all the arteries, and they increase the blood flow, and pain goes away. Ultimately, though, we still see weakened cells in the heart. Nitroglycerin tablets are a band-aid over the problem. The other situation is the myocardial infarction. Now, both angina and the myocardial infarction, the classic heart attack, deal with ischemia, not enough oxygen going to the cells. In angina, it's a transitory event. It comes and then it goes, usually. But with the myocardial infarction, if it isn't corrected, it becomes a permanent block. You have enough of a blockage in a coronary artery to shut down the blood flow to the muscle cells below the blockage. They'll die after an hour. They can run off of stored oxygen in the myoglobin for about an hour, about 60 minutes, more or less. Uh, and after that, the cells start to die. Uh, and we know that muscle cells don't reproduce. So when the cells are dead, we have to replace them with scar tissue. The fibroblasts go to work, but not until the macrophages have taken out all the dead and damaged muscle cells. And that's where, if your patient does not have a stent put in, is not treated for uh, a blockage, and survives the initial attack, they may very easily die a week to 10 days later once the macrophages are going to work. Okay. Ischemia, again, that's a term for a reduction in blood flow. Angina is caused by a transitory, temporary, reversible type of ischemia. Nitroglycerin tablets under the tongue. Nitroglycerin becomes nitric oxide as it dissolves and causes a body-wide vasodilation. That's why you would be reluctant to administer nitroglycerin tablets to a male patient that had taken an erectile dysfunction drug shortly before they had their cardiac event, because they're already vasodilated. And so it would probably be a bad thing to vasodilate them on top of the effects of the erectile dysfunction drug. Because remember, the erectile dysfunction drugs in males work body-wide. They don't just focus the blood vessels in the penis, they work body-wide. And so this animation shows you how our coronary artery becomes blocked, and then, partially blocked, it fills up, and we can still function at 95% blocked. Not well, but we can still function. Once we get to the complete blockage, and you see in the heart there, where the black spot is forming, that's where the cells will die unless the blockage is removed. Intramyocardial infarction, we block an infarct is a blockage. And, we have to remove the blockage. Obviously the catheterization with angioplasty and a stent is usually the number one choice here, but you can use tissue plasminogen activator to destroy a clot, because the clot is full of plasminogen. So remember, from bleeding, and bleeding control, where you form your clot and there's plasminogen embedded in the clot, and then the plasminogen is activated and starts dissolving the clot. Well, TPA administered to a patient with a blockage, that can start breaking down the clot itself without damaging the tissue. Perhaps they're not healthy enough to have angioplasty. And there's always that possibility too. And of course, a procedure that's been around for a long, long time, uh, coronary artery bypass. Uh, at one time, there were about 300,000 bypass surgeries a year taking place. The initial procedure would be to take the great saphenous vein out of the medial surface of the leg, or medial side of the leg, uh, and then reattach it, cut it off, and we can live without our great saphenous vein. And you would tie the great saphenous vein into the aorta right here and below the blockage here. And then you would have a continuous blood flow past the blockage, and then you could treat the blockage, with medications or TPA or whatever. Uh, and that's fine. But it was found that veins accumulate plaque at a faster rate than arteries do. So here you have this vein being exposed to HDLs and LDLs and cholesterol, and now it is getting blocked, and it gets plaque accumulation occurs at a faster rate because many patients, they have this bypass surgery. It's a pretty violent procedure. You cut open the chest, and you have to use bolt cutters to cut through the ribs to crack them apart. And then you use rib spreaders to open up the chest to get in there to uh, do this bypass surgery, and then you have to put everything back together again. Whereas angioplasty, you just run up through the artery into the heart, and you find the blockage, and you blow up a balloon and drop your stent. The problem with the great saphenous vein was twofold. One, it would accumulate plaque faster than an artery would. Secondly, you're making, first of all, you're cutting out the uh, great saphenous vein. So you got to cut and tie in two locations in the leg. Then you're cutting into the aorta and cutting into the blocked artery. And that does pose a certain amount of risk. A better procedure that's been developed is using one of the mammary arteries or one of the vertebral arteries here. This is the aortic arch right here. And coming off, you have there's the left common carotid, there is the left subclavian, and coming off that is one of the mammary arteries here. And by simply disconnecting one of those arteries from the mammary glands, and their blood supply is overly redundant. And so you make one cut and block that, take that off, and then simply direct this down here and attach that to, in this case, it's the anterior descending artery or the anterior interventricular in the middle of the heart. Tie it in, and your blood supply now is coming from an artery to an artery, instead of the aorta to a vein to an artery. And it is a less invasive procedure, requires less cuts, it requires less joins, connections here, so that you have it's less likely for this to fail. So, and but this works. Bypass surgery will, uh, you know, is a lifesaver for your patients. And in some patients, this is the only option they have. If they can't stent, if they can't ablate the blockages inside the arteries, then bypass is their if they're hoping for a positive outcome, this is their procedure. But stenting is much easier, it's much safer, it's less invasive. And that is the end of heart physiology. So let's take a stop here, and I want to go we're going to shift gears completely, and we're going to go into the urinary system physiology. So give me a minute here to bring that up. And if you have any questions the on the heart physiology, feel free to ask them, shoot me an email, whatever. So you're gonna hear more about the heart physiology on Thursday when we dissect the hearts and look at the heart circulatory system, and of course we're going to have the anatomage to show you uh, the the structures inside the heart as they work. Okay, shifting gears now. Everybody should see the urinary system.